So first pass is, that is highlighted in black, is through and through stitch. The second pass is, that is the reverse white, that include mucosa and part of the submucosa. So again, we are out. So now the third pass that will be on the duodenal side will be from the submucosa to mucosa, and fourth pass is again full thickness, that is highlighted in the red. That will be the fourth pass that will come from the mucosa to the serosa. Welcome to our channel, viewers. So this is part 2 of Stricturoplasty and Pyloroplasty series, video series. And in the first part, we have already discussed about the theoretical part. So in this part, we will discuss about Gambee Stitch, followed by live demonstration during Heineke-Mikulicz Stricturoplasty. For a case of corrosive injection with the esophageal and partial gastric outlet obstruction. So friends, this video is available exclusively on our app and in members only section of the YouTube. So if you want to watch the premium HD quality, either you can download our app or join the channel. The link for both is available in the description of this video. The highlights of this video will be Gambee Stitch and live surgery demonstration of Gambee Stitch with Heineke-Mikulicz Pyloroplasty. And the second part of Heineke-Mikulicz for a chronic DU will be demonstrated in the third part of this video series. As this first part, we have kept delivery as a simple case, and the second case will be a bit more complicated. So let's, move step by step from theoretical to simple case and to a complicated case. So the quick recap, we have already discussed in detail about the Finny pyloroplasty, the application of Heineke-Mikulicz and its application in pyloroplasty and or small bowel stricture has already been discussed. Javelin procedure was discussed in detail, that is side-to-side gastroduodenoscopy and mycology stricturoplasty. So friends, if you have not watched our previous video, that is theoretical discussion, which is available on our app, website, and on our YouTube channel also. So please watch that video, then you will have better understanding of these live surgery video after the theoretical understanding. Which is the most skewered stitch ever designed, and whenever we have a difficulty or we think that we are not able to oppose the two surfaces properly, always use Gambee, and Gambee should be the part of armamentarium of every surgeon, and it has basically two parts. It is an interrupted closure, and it inverts the mucosa west into the lumen. So first is suture is passed from the outside, full thickness pass, then it is passed back to the mucosa to exit through the submucosal layer on the same side. Then it is passed from the submucosa to the mucosa on opposite side. And final pass is again full thickness. You will better understand with the pictorial depiction and during the live surgery. So this is the graphic representation of the Gambee stitch. So friends, just consider that the stomach serosa is on your right side as highlighted here. So first pass is, that is highlighted in black, is through and through stitch. The second pass is, that is the reverse white, that include mucosa and part of the submucosa. So again, we are out. So now the third pass that will be on the duodenal side will be from the submucosa to mucosa, and fourth pass is again full thickness, that is highlighted in the red. That will be the fourth pass that will come from the mucosa to the serosa. So these are four parts, and it basically inverts the mucosa beautifully, and there's a beautiful apposition. Only a disadvantage, I will say, it is a bit time consuming, but time is never an issue, as I already said many times before, that whenever we are operating, time is never an issue. It is the outcome that matters. So just remember this configuration, and then we will understand the Gambee stitch during the live surgery demonstration during the subsequent part of this video. So this was a patient, 41-year-old male. He was a smoker, addict, marijuana addict, alcoholic. Patient had an accidental ingestion of the corrosive, and the patient had a esophageal stricture, lower esophageal stricture. He was on dilatation program, and during his previous endoscopic evaluation, he was also found to have a pyloric narrowing, which was partially negotiable. he was tolerating liquids. So during one of his dilatation, he had iatrogenic perforation of the esophagus. So patient was shifted toward a surgical site. We planned for him his pyloroplasty and feeding in gynostomy. The patient was emaciated with a low BMI of 12. There was no systemic finding except for the very poor nutrition level, and the CCT abdomen showed a contrast leak, which was approximately 3 centimeter proximal to the gastroesophageal junction, with pooling of the contrast in the lower mediastinum, and associated lung finding were basal atelectasis and consolidation on the left side. Post-perforation, patient had a very stormy course. He had fungal sepsis and he was in frank shock. So we optimized the patient, started TPN, and then we started antibiotics and antifungal that liposomal amphotericin B was given for 14 days. And after optimization, patient was taken up for the surgery. So this is the live video now. We have given a limited midline exploratory laparotomy